Hi, this is my name, Alexandra Gervais, and the date 12/12/22. So this is my case connection for responses. So I chose, first was case number 2. So there's the 3 scenarios that we have to talk about with enzyme deficiency, amino acids that aren't metabolized, any amino acids that become essential, and then potential vitamin supplements. It looks like metabolism that they could help with. So the first one's about like a full-term girl that was a normal vaginal delivery. She's released at 3 days old, comes back at 9 days old. She has increased serum BCAAs in her blood, branched chain amino acids. So the most likely diagnosis here would be maple syrup urine disease, and we see this through the higher serum levels of the BCAAs, as well as increased levels of the alpha keto acids in the urine. So that's what makes the urines have its like kind of sickly sweet smell. Hence why it's called maple syrup urine disease. So the metabolic deficiency lies in the inhibition of the oxidative carboxylation of these branched chain amino acids, which are leucine, valine, and isoleucine. And this disease presents very early in age, hence why she's like 9 days old at this point. And it is life-threatening if not treated. So treatments for this include limiting BCAAs in the diet, and sources of this include like meats, seafood, nuts, yogurt, stuff like that. And then another thing that I saw was that we want to decrease metabolic processes that increase protein catabolism, so avoiding fevers and dehydration, stuff like that. So coupled with this dietary, the recommended supplement would be vitamin B1 or thiamine. And thiamine is a cofactor for catalyzing the BCKAD enzyme, allowing for a reduction in the serum levels of BCAAs, so that would definitely help. Okay, so next one was a 69-year-old woman, 30-year history of low back pain, joint pain, blue-gray pigmented macules on cartilage areas of the body, and a history of aortic stenosis. Okay, so from this we can likely deduce that she is diagnosed with alkaptonuric ochronosis, or it's like alkaptonuria, also called black urine disease. So the disruption in this pathway is caused by the buildup in homogentisic acid due to a deficiency in homogentisic acid oxidase. So this really would disrupt the degradation of tyrosine and phenylalanine. So because of this, it makes tyrosine an essential amino acid, so it has to be consumed in the diet. So when I was looking at this, I couldn't really find a whole lot of extensive research that had a clear treatment for this. There was like something about like vitamin C therapy that didn't prove to have any long-term positive effects. But there are ways to improve symptoms like joint replacement therapy, pain management, and a low-protein diet. I thought like the most ideal therapy would be like an enzyme replacement, specifically like replacing the HGD in the tyrosine degradation pathway. But it's one of those things that the risks outweigh the benefits, because if there's any issue with disrupting the pathway at the wrong time, it can cause a buildup of succinyl acetone, and that's highly toxic to hepatocytes. So like I said, the risks would outweigh the benefits at this point. It could be fatal. So they're still working on some kind of research with something that would help with that pathway. So scenario 3, 40-year-old infant, birth weight is 5.9 pounds. And then a phenylalanine level of 6.6, which is too high. So from this, we can likely deduce that it's phenylketonuria, or PKU. It's also called, I saw it was like hyperphenylalaninemia. That's so long. I like PKU better. But the enzyme that's deficient is phenylalanine hydroxylase, and that's kind of along the same pathway where it would be a disruption converting phenylalanine to tyrosine. And so that would again make tyrosine go from a non-essential amino acid to an essential amino acid that needs to be consumed in the diet. But this is kind of interesting because we have to limit phenylalanine and aspartame ingestion. And since this is like presenting so early in life, it's not really conducive to meeting growth requirements for a newborn to limit like a low protein diet with no phenylalanine and no aspartame. So there needs to be like a commercially made supplement of like formula with protein that's not derived from phenylalanine or aspartame. So that's one way that we need to help with the diet. And then I saw that there's one drug that's currently in clinical trials. It's called sapropterin dihydrochloride. The trade name is called Kuvan, and it's actually in pretty advanced stages of the clinical trial. But it's basically a synthetic form of BH4, which is a cofactor for the reaction catalyzed by PAH, the phenylalanine hydroxylase. And so this will help catalyze the production of the tyrosine. So it kind of helps to lower phenylalanine in the blood by metabolizing it to tyrosine. So this is a cool drug that's currently in research. So okay, and then I have my works cited on that. And then the next case I chose was case number 3 because this one was kind of tough at first, at least for me. So this is the 47-year-old man that presented with pain in his great right toe. He's diagnosed with gout. He confirms that he's drinking high amounts of diet soda, which contain fructose now. And then he has blood and urine samples, which shows his plasma urate and his urinary uric acid. And then we need to decide which mechanism is the cause for his gout and talk about why the other ones aren't it. And then he talks about what the potential impact of the dietary modification on the presentation of his gout is when he's drinking more regular soda than diet soda. So in this patient, from like the physical examination and the lab values, we can infer that the cause of his gout is more likely the overproduction of purines as opposed to the underexcretion of uric acid. So the uric acid underexcretion is usually a diagnosis in like 90% of these patients. However, in this particular patient, we see an elevated plasma urate level, which would be due to like the increased availability of the PRPP, and that would be more consistent with an overproduction in the purines. So, and as noted, there is a decrease in the urinary uric acid, which would align with the underproduction of the underexcretion of uric acid, but it wouldn't be coupled with that high plasma urate level. So that leads me to believe that although it could be one or the other, I'm more inclined to lean towards the overproduction with that high plasma urate level, just by going by those two lab values and then the pathophysiology of it. So I want to explain why it's not the second one, which is it would not be likely due to the decreased salvage of the purines, because that would necessitate a decrease in the synthesis of purines, but we know that's not happening because there is a high level of purine production. So one of the diseases with that would be like Lesch-Nyhan's disease, and there can be further testing to confirm this, especially testing for hypoxanthine guanine phosphoribosyltransferase, so HGPRT. If you saw an increase in that on some serum tests, that would note that maybe that would be that the decreased salvage of purines might be the issue. But with his physical symptoms, there would be like a family history of gout, and then we'd likely see other pretty prominent symptoms like cognitive deficits, behavioral changes like biting fingers, lips, and it usually presents in younger people, and he's in his late 40s, I think. So I highly doubt that that's going to be an issue. It doesn't align like with a clinical picture, but we could also always do HGPRT testing to really rule it out. So like I said, I'm more inclined to go with the overproduction of purines due to these two lab values alone, but I wouldn't rely solely on that. I would want to do an extensive family history, and then I would also want to schedule him for a procedure of aspiration of the synovial joint fluid and send that off for pathology, and I think that could really tell us what the root cause of all of this would be. So yeah, that's how I would address that one. Thank you so much. Oh wait, there's one more part. He said that he switched from diet soda to regular soda. So this will really cause extreme exacerbation, especially considering he's consuming 4 to 5 liters, because the fructose breaks down into purines, and that means more uric crystals that will be deposited into the joints, more inflammation, more pain. So we could talk about decreasing his fructose intake. And then also I found something that was like, it said that cherry juice, especially tart cherry juice, actually promotes the excretion of uric acid, so that could also help alleviate some of his pain if he adds cherry juice to his diet. So just a suggestion for the patient. Yeah. Okay, now I'm really done. Thank you.